Hi, everybody. So we are going to go ahead and get started. So first off, I am going to hold a exam review in this room right after class today, okay? So if you requested to view your test, I have printouts and we can view the exam and go over the questions right after lecture in this room, okay? So you don't have to go anywhere. And that shouldn't take more than about an hour, okay? And if you can't come today, I'll also be having an opportunity to view your exam this Friday during my office hours from 1:30 to 4 p.m. And that's going to be in room 518, which is just across the hall from my office, okay? And I think that Julie already sent out the sign-up request, okay? So again, we just ask that you let us know that you are coming so we can print your exam ahead of time. And so we don't have to print exams for people who are not coming. That way we save some trees, okay? And if you can't go to today or Friday, email me and we can hopefully arrange for a time for you to come in and take a look at your test. So today we are going to cover, so where's today here? 11:06. So what we're actually going to start, we're going to start talking about the cardiovascular pathophysiology section, and we're going to start with blood vessel disorders or disorders of circulation, okay? Where we left off last week with the normal physiology was, we stopped right before I started talking about the control of blood pressure. So what I'm going to do is I'm going to actually discuss the control of blood pressure along with hypertension. Okay? So when we get to the topic of hypertension, I'm going to review the normal mechanism for blood pressure control and then talk about pathologically elevated blood pressure in the form of hypertension. Okay? So what we're going to do is we're going to be using the PowerPoint, the blood vessel disorders PowerPoint, and also the hyperlipidemia, okay, in case you're keeping track. So when we talk about the disorders that affect cardiovascular function, I like to talk about them in two sections. Talk about disorders that affect heart function or heart disease, and that's the part 2. And first I like to talk about blood vessel disorders or disorders that interrupt or affect circulation. And there are a wide variety of disorders that will affect blood flow. And they can be categorized based on the root cause. So disturbances in blood flow can result from pathological changes in things like the vessel wall, okay? And the topic that we're going to spend quite a lot of time on is atherosclerosis, because that's a very, very common blood vessel disorder. Okay? So atherosclerosis or atherosclerotic plaque is a very clinically important disorder for us to talk about. But also things like vasculitis, which is general inflammation of the vessel wall that can affect blood flow. So lots of disorders of blood flow that stem from vessel wall problems. We also see things like acute vessel obstruction, okay? And acute vessel obstruction most commonly is caused by blood clots, okay? Acute vessel obstruction can be caused by a thrombus, which is a blood clot, or an embolus, which is really any substance that travels through the bloodstream and can obstruct a vessel. Okay? And emboli most commonly originate are blood clots that break off where they form. Okay? So if a blood vessel is getting obstructed, it's most likely obstructed because of a blood clot. Either a clot that's formed at the location it's obstructing, or a blood clot that broke off its original place where it formed and traveled and blocked a downstream vessel. But we also have vessel obstruction in the form of things like vasospasm. And this is where you get acute constriction of the smooth muscle that lines the wall. And there's a condition called Raynaud's phenomenon that is quite common, and it's most commonly caused by vasospasm. So with Raynaud's phenomenon, Raynaud's is a clinical syndrome or clinical sign. Okay? And what happens with an individual with Raynaud's is they have a temperature-dependent change in blood flow to their extremities, namely their fingers and their feet, especially their toes. Okay? So it's temperature-dependent. So usually when they're exposed to cold, their fingers and toes will either blanch and turn almost white, or they'll turn bluish purple. Okay? So when exposed to cold, the fingertips and the toes either blanch and turn white, or they turn bluish purple. Okay? And when they are then exposed to warmth, blood flow returns, and they can often experience redness in their fingers and toes that sometimes accompanies some pain. Okay? And there are many causes that can result in Raynaud's phenomenon. Okay? But a very common one is inappropriate vasospasm. Okay? We also have blood vessel disorders that are caused by abnormal dilation of blood vessels. And these are conditions that are related to aneurysms. Okay. So this inappropriate dilation impairs blood flow because blood starts pooling in an area, or blood gets displaced out of the blood vessel. But also aneurysms can rupture and can reduce blood flow because of rupture and bleeding. Okay. And then we also see interruptions of blood flow or problems with blood flow because of compression of vessels from outside forces. Okay. So you can have compression of vessels as a result of tumors that form, right, and then impinge upon nearby blood vessels. Okay. You can have a firm surface impinge blood flow. Okay. And that usually results in what's called a pressure ulcer. Okay. And so pressure ulcers, which are a significant problem and very relevant to nursing care, is usually caused by extended bed rest and poor repositioning, inadequate repositioning. And pressure ulcers are essentially ischemic ulcers. They are a reduction in blood flow to cutaneous tissue, and then the tissue breaks down. Okay? And you get some stage of ulcer. Okay? And where do we see pressure ulcers most commonly? Near bony prominences, right? So where cutaneous tissue and skin is pressed against a bony prominence. Okay? because that's where you're going to see these pressure points. Okay. And what you'll find is the patients who are the most vulnerable to getting pressure ulcers are the ones who are vulnerable to poor circulation. Okay? So patients with hypertension, patients with diabetes, okay, especially if those conditions are poorly controlled. And of course, those conditions often come together, right, occur together. So a patient like that who are at high risk, they can develop a serious pressure ulcer in just a couple of days of bed rest. Okay? While another person who has good circulation and is low risk can be under bed rest for an extended period of time and not develop pressure ulcers. Okay? And then interestingly, you can even get compression of vessels caused by edema. And this is often referred to as compartment syndrome. And this happens frequently, or it can happen, particularly with crushing injuries. So injuries where tissue or limbs get crushed, okay? You have so much inflammation and so much edema happening that the swelling starts to get impeded by these fascia compartments. These compartments of fascia is connective tissue that holds things like muscle groups together. Okay? And the swelling pushes against that fascia, and it causes pressure on blood vessels, and you don't get blood flow. Okay. So even extensive edema can impede blood flow through an area. Okay. And so interrupted blood flow, it causes, depending on whether it affects arteries or veins, it will impair delivery of oxygen and nutrients to tissues when arteries are affected, and it will impair clearance of blood from capillaries, and impaired removal of waste from tissues, and impaired return of blood to the heart when veins are affected. Okay? So slightly different consequences depending on whether you have interrupted blood flow affecting arteries versus veins. So an important topic within blood vessel disorders is atherosclerosis. Atherosclerosis is, I read once in a cardiology textbook that occult atherosclerosis in adults is more common than not. Okay? So if you look at an adult arteries, you are more likely to see unnoticed atherosclerosis than you are not to see it. Okay? So not having some atherosclerosis as an adult has become actually the rarity, okay, rather than the norm. This is how pervasive it is. So what atherosclerosis is, number one in that statement right there is it's a disease of medium to large arteries. Okay, so number one, atherosclerosis only affects arteries, does not affect veins, does not affect small arteries or arterioles. Okay? Only medium to large sized arteries are affected. And there's an important reason for that. I'll talk about that in a minute. And it involves the accumulation of lipid, smooth muscle, and collagen within the intima of artery vessel walls, okay, arterial vessel walls. So it's an accumulation of lipid, smooth muscle, and collagen in the intima of the arterial walls. Now, here I've got a cross-section of an artery wall, and your right side of the slide is the lumen side, so that's where you would find blood flow, and then the left side here is the exterior of the artery. So you have this on the outside, you've got this connective tissue, okay? You've got this very thick layer of smooth muscle. You have this layer of endothelium, right? Those endothelial cells that line the interior of the vessel. And a little bit of connective tissue right underneath the endothelium. So notice over here, on the bottom, the intima of this vessel is essentially the endothelium and just that sparse connective tissue underneath the endothelium. Okay. So when we're talking about atherosclerosis, we're talking about an accumulation of lipid, smooth muscle, and collagen in that area just behind the endothelial cells. Okay? And this is a healthy artery wall. You can see that intima doesn't take up much space. It's not supposed to take up much space. So when you have an accumulation of this material in the intima, it will present an impingement on the lumen of the vessel. It will narrow the lumen of the vessel. Okay? And that is going to affect blood flow. So, what causes atherosclerosis? Atherosclerosis, these plaques, they represent scar tissue. They represent the result of chronic inflammation on the artery wall. Okay? So these plaques are a result of chronic inflammation. What causes chronic inflammation? Even more fundamentally, what causes chronic inflammation anywhere? Injury. Injury, stress, injury, right? What kind of injury? Persistent injury. Unrelenting, persistent injury. Okay? Where you have this attempt to heal that is frustrated by ongoing inflammation. Okay? So atherosclerotic plaque is a result of chronic and persistent injury to the endothelium that triggers chronic inflammation. Okay? Now, what sorts of things can injure the endothelium? And you said one, right? Patricia, you said one. Hypertension, right? So we can have hypertensive injury to the endothelium. Okay? Things like smoking causes direct injury to the endothelium. Hyperglycemia causes direct injury to the endothelium. And one factor which seems to increase the risk of atherosclerosis more than any of these other factors. Any guesses? I heard somebody say hyperlipidemia. Yes. Hyperlipidemia, in particular, hypercholesterolemia, elevated LDLs. Okay? So more than any of these other sources of endothelial injury, elevated cholesterol, elevated LDLs has the strongest risk factor for developing plaque. Okay? Now, on that note, we're going to switch for a second and talk about hyperlipidemia before we then come back and talk about atherosclerosis. Okay? So we're going to take a little bit of a side trip on this journey that we're taking and talk about hyperlipidemia. And it's because hyperlipidemia is the strongest risk factor for the development of atherosclerosis. Okay? So, hyperlipidemia, what does that mean? Hyperlipidemia technically simply means elevated levels of blood lipids. Okay? And we have 3 types of lipids in the body. Or I should say that lipids are found in 3 forms in the body: triglycerides, phospholipids, and cholesterol. Okay? Triglycerides, phospholipids, and cholesterol. Now, there are 2 that we often describe as being structural lipids. What were those 2? In that list? Phospholipids and cholesterol. Okay? Phospholipids and cholesterol are structural lipids, meaning that they are important lipids in forming the structure of cells. Okay? And it's namely the plasma membrane. Right? The membranes are all made of phospholipids with some cholesterol incorporated into them. Okay. So we use phospholipids and cholesterol for structure throughout our body. What else do we use cholesterol for? Steroid hormones. All steroid hormones. All steroid hormones are formed from cholesterol. Okay? What's the other? It's a narrow list. What's the other thing that we need cholesterol for? I'll give you a hint. The liver uses it to produce this. Bile. Okay? Those are the 3, bile is hilarious. It is. Those are the 3 main functions that the body has for cholesterol: structure, forming steroid hormones, and producing bile. Okay? Triglycerides we generally use for either storage in adipose tissue or breaking them down for energy. Okay? So triglycerides are really part of our energy balance in the body, either stored or being utilized. Now, because lipids are not water-soluble, we can't have them moving around the bloodstream nilly-willy, okay? If we just had triglycerides and phospholipids and cholesterol moving around the bloodstream, what would happen is that they would all bunch together, right, to exclude water, and we've got problems. So lipid in the body must be packaged in water-soluble friendly ways, okay? Lipids in the body must be packaged. And the way that we package lipid is by forming what we call lipoproteins. Okay? And lipoproteins, they are literally packages. Let me show you what one of them looks like. They literally are little packages of lipid. Okay? And so what do we have in this package? Well, phospholipids are doing what they do best, forming the outer membrane. Okay? We have, and those phospholipids are the best at forming those membranes because they happen to have a water-soluble head that they can interact with any aqueous solution. And their fatty tails are pointing on the inside where the rest of the lipid are located. Okay? So we've got cholesterol in yellow, we've got triglycerides in green. Okay? And then we have, on the outside, we have proteins, apoproteins. Okay? And there's a variety of apoproteins. And what these proteins do is they signal to target cells what is contained within these lipoproteins. Okay? So these apoproteins are used as recognition, and it determines what the metabolic fate of this lipoprotein. Excuse me. Okay? So different apoproteins signify different types of lipoproteins. And there are generally 5 types of lipoproteins. We have what are called chylomicrons. Chylomicrons are predominantly composed of triglycerides. Okay? Chylomicrons are predominantly composed of triglycerides. And that's their purpose, is to carry triglycerides through the bloodstream. There are what we call very low density lipoproteins, intermediate density lipoproteins, and low density lipoproteins. Okay? So the 3 there, they have varying amounts of cholesterol. Okay? They have varying amounts of cholesterol. And LDLs, which are more numerous than the rest, LDLs are predominantly made up of cholesterol, and their function is to carry cholesterol in the bloodstream. And then we have high-density lipoproteins. High-density lipoproteins have the highest protein content compared to lipid. Okay. High-density lipoproteins, HDLs, they are synthesized by the liver, and their job is to control or help limit the amount of LDLs that are in circulation. Okay? So HDLs, they are not really functioning as fat carriers. What they're doing is actually helping to regulate the amount of LDLs in circulation. Okay? So all of these names, many of these names refer to density because that's how we categorize them. Okay? When we take a plasma sample, okay, we take a blood sample, we can remove red blood cells and white blood cells and platelets and just look at the plasma. And then the plasma is spun in a centrifuge at very high speeds so that everything with the highest density gets pushed to the bottom of the tube. And what you'll find is that the lipoproteins with the lowest density are the chylomicrons. Okay? And what gives a lipoprotein low density is the fat content. And what increases the density of these lipoproteins is the protein. So if you spin this plasma sample, you get chylomicrons on top, HDLs on the bottom, and LDLs right above the HDLs. Okay? And those are really those are the three lipoproteins that you should be comfortable with what they are, what the purpose is, okay? Chylomicrons, LDLs, and HDLs. So where are all these lipoproteins produced, and where are they headed, and like what's the life cycle of these lipoproteins? So first off, we have to start with ingested, with the food that we eat, okay? So if we start with the food that we eat, we consume food that contains triglycerides and cholesterol. Okay? Now, the triglycerides and cholesterol that we consume are packaged as chylomicrons, okay? And they're actually packaged that way within the intestines. So when we consume a food and we're absorbing all of the contents of that food, we take the triglycerides and the cholesterol and we package them into chylomicrons. Okay? And then the blood that leaves the GI tract, where's the first place that blood goes? To the liver, right? It goes into the portal circulation and it goes to the liver. And what happens is some of those chylomicrons enter the liver, okay, get absorbed, taken up by the liver. Some of those chylomicrons get into general circulation and are delivered to fat cells and skeletal muscle to just be used as energy, right? The chylomicrons that are taken up by the liver, they start to get disassembled, okay? And the liver, whatever cholesterol is there, the liver can take that cholesterol and use it to make bile. But the liver will also produce VLDLs that in circulation become LDLs. Everybody see that? So the liver will produce VLDLs that in circulation will get repackaged into LDLs. And the liver also produces HDLs. Okay? Now the LDLs, so now we're post-liver, and we've got chylomicrons going off to tissue to provide triglycerides for energy. We've got LDLs and we've got HDLs. The LDLs in circulation, they ideally, the number of LDLs ideally, we want to be rather low because our body's cholesterol needs are modest. Okay? And the cells that need cholesterol will take up cholesterol through a pathway that we call receptor dependent. Okay? Those cells will have an LDL receptor. LDLs will attach to that receptor, and it'll be taken up by that tissue. Who's going to tell me the organ that has the greatest density of LDL receptors? I'll give you a hint. It's on the slide. The liver. That's right. Okay? The liver actually has the greatest density of LDLs. LDL receptors, okay? Which means that the liver is the greatest consumer of LDLs because it's got to constantly make bile. Now, LDLs that are not taken up through that receptor pathway can also be taken out of the bloodstream by HDL. So the HDLs in circulation, when they come up against an LDL, will attach to the LDL and carry it back to the liver. And we call that the reverse cholesterol pathway, or reverse cholesterol transport. Okay? Now, the reason why we want circulating LDLs to be low is because we don't want any excess LDL that isn't getting taken up by the receptor pathway or isn't taken up by HDLs, because the leftover LDLs end up getting what we call oxidized by circulating reactive oxygen species, and they injure the endothelial wall. So excess LDL Luckily, I have batteries, or else I'd be shouting. The excess LDLs, okay, that aren't getting taken up by the receptor uptake or HDLs, those LDLs are vulnerable to oxidation by reactive oxygen species. Those oxygen radicals, they turn the LDLs into radicals. And those LDLs then injure those endothelial cells. Okay? And that is why elevated LDLs are the greatest risk factor for development of plaque, okay? Because they're just basically, we're arming all of these LDLs to do damage to our artery wall. Mm-hmm. Yes. It's a chemical change. So basically, reactive oxygen species have an unpaired electron in its outermost shell. And electrons hate being by themselves. So what they will do is they will steal an electron from anything they bump up against. And when they do that to the LDLs, those LDLs become oxidized, and they start disrupting other bonds and damage the cells. Yeah. Exactly. That's exactly right. Okay. So these oxidized LDLs do damage to the artery wall. Okay. And then that injury to the artery wall, well, what reaction, what's triggered with injury? Inflammation. Okay. And then who migrates to the site of inflammation? Neutrophils and monocytes and macrophages. Okay. And so on this slide, it shows that the LDLs are getting taken out of circulation either by the receptor pathway, the HDL pathway, or what's called in green the scavenger pathway. And the scavenger pathway are the neutrophils and the macrophages. Okay? That they have to come in and eat up those LDLs after they've already caused injury. Okay? And that's where we're going to, that injury that they're doing and that inflammatory response is the beginning of our conversation of atherosclerosis. But before I talk about that, there's one more topic, or there's one more thing. So hyperlipidemia is the most common cause of, or the most common risk factor, or strongest risk factor for atherosclerotic plaque. But hyperlipidemia is a very general term, and it means basically abnormal numbers of any of these lipoproteins. Okay? Abnormal numbers of triglycerides or cholesterol or any of them. However, ideally what we want is low triglycerides, low LDLs, and high HDLs. Okay? That's the profile we want. Low triglycerides, low LDLs, and high HDLs. Okay? And so to be more precise in terms of risk factors for atherosclerosis, what the highest risk factor is hypercholesterolemia, okay, which is elevated LDLs. And elevated LDLs can be caused either by what we call primary hypercholesterolemia or secondary hypercholesterolemia. Okay. And secondary hypercholesterolemia is much more common. This is when the elevated LDLs are associated with lifestyle and behavior. Okay, so sedentary lifestyle, poor diet, okay? Especially a diet that is high in trans fats. For some reason, those artificial fats, and what's amazing is that they used to be considered like health food, right? Margarine. So people would switch from like butter to margarine. But margarine is they take basically vegetable oil and they hydrogenate the fats. They turn it into a solid. And those hydrogenated oils, those trans fats, what we have found over time is they result in the greatest production of LDLs by the body. Okay. So those sort of manufactured or manipulated fats seem to be the worst for us. Okay. Primary hypercholesterolemia, on the other hand, is completely independent of BMI, diet, lifestyle. People with primary hypercholesterolemia, they have a genetic predisposition to having elevated LDLs. Okay? This is when you see someone who is not obese at all. They seem to have a good diet and good healthy lifestyle, but they still have elevated cholesterol, and it's something that has run in their families. Okay? And that's when someone really needs medication to control their cholesterol level. It's not going to change based on a change in their lifestyle. And so these genetic vulnerabilities are often due to things like defective apoproteins, right, that impair receptor uptake of LDLs, or having defective LDL receptors that impair the uptake of LDLs. Okay? But it's some sort of genetic problem in how LDLs are produced and removed from the bloodstream. Okay. Okay. So atherosclerosis is a disease of medium to large size arteries, and it involves the accumulation of lipid, muscle, and collagen in the intima, okay, which is the area just behind the endothelial cells. Okay. It is caused by persistent endothelial injury developing into chronic inflammation. Now, only medium to large-sized arteries and not veins. The reason for that is when we see atherosclerotic plaque formation, it's not usually a persistent injury that is isolated. It's not usually just one injury, right? One kind of injury. It's usually sort of a layered injuries and layered stress that accumulates and tips the scale into this chronic inflammatory process. And there seems to be a minimum blood pressure that vessels have to be under in order for atherosclerotic plaque to even form. Okay. And so the reason why medium to large size arteries get plaques is because they are high pressure vessels. Okay. That pressure, that stress of that pressure seems to be necessary to make a vessel vulnerable. Which should tell you already that if someone has hypertension, that is going to dramatically increase their risk for atherosclerosis, even if their cholesterol levels are controlled. Okay? So again, it's often multiple factors that are leading to multiple forms of injury that are leading to these plaques. Common sites that we see especially the most severe atherosclerotic plaques. So where we see them, large vessels, right? So we're seeing them in the thoracic aorta, okay? We're seeing them in the abdominal aorta, in the iliac branches, right? Iliac arteries. We're seeing them in the femoral and popliteal arteries. Okay? These are huge vessels. And it's really bad news when you have a plaque in one of these places, because now you have, if the plaque is large enough to cause decreased blood flow, what you have is a lot of tissue downstream to those big arteries. Okay? So this is a real problem when you have severe atherosclerosis. We also see atherosclerosis commonly in the carotids. Okay? We see atherosclerosis in a set of vessels that are located at the base of the brain. It's this anastomosis of vessels up here. Okay. This is, like I said, it's located at the base of the brain. It's called the circle of Willis. Okay. And it is the set of vessels that these carotid arteries feed into. Okay. And that circle of arteries then branches into smaller vessels that perfuse the rest of the brain. Okay. one of my first patients in my med-surg rotation when I went to nursing school. So I went to nursing school. I was a professor here at Columbia. This was in 2009. So I was like coming here and teaching my classes and then driving to school. And nobody knew what I did, you know. The first patient I had in my med-surg rotation, he came into the hospital because he had these episodes where he couldn't speak, right? Where he would just lose the ability to speak for like an hour. And what they found was that both of his carotid arteries were like 50% blocked. And that he was just having these moments where the blood flow was so low through those carotid arteries that he just lost the ability to speak. Okay? So really dramatic problems arise when you have plaques in these locations. And then another place that's very common for plaques are in the carotid arteries. Okay? And the carotid arteries, left and right carotid arteries, I'm sorry, not carotid, I'm sorry, coronary. I'm saying weird words today. The coronary arteries are the arteries that perfuse the heart. Okay? And so plaques in those arteries are going to impair blood flow to the heart and create a condition that we call ischemic heart disease, okay? Which is by far the most common form of heart disease in the developed world. Okay. So, we got plaque, which is bad. Disease represents pathology. And then we have something called fatty streaks, which shares some similarities with the plaques. But fatty streaks are not abnormal. They're incredibly common. Okay? So fatty streaks, and you can kind of see it, but basically what you have here is post-mortem, right? So this is tissue taken from a large artery, and those holes are basically pins. Somebody has pinned down this artery. And these red streaks on the wall of the interior wall of this artery are streaks of lipid in the intima. Okay? And we call them fatty streaks. So fatty streaks are caused by the deposition of lipid-engorged macrophages. And we called those lipid-engorged macrophages foam cells. Okay? Foam, F-O-A-M. And the lipid that they are engorged with, anybody want to guess? Cholesterol. Okay? They are engorged with cholesterol. And specifically, they are engorged with oxidized LDLs. Okay? And so you have these engorged, LDL-engorged macrophages just under the endothelium. And what you'll see if you could look at an area of an artery, what you would find is these fatty streaks will appear, and then they will resolve. They'll go away. Okay? And you will start to see these fatty streaks in arteries of children as young as 1 year old. The number, if you take a look at the same artery at different periods of time in a child's life, the number of fatty streaks at any given time will increase until they get to about age 20. And then that number plateaus. Okay? And it's either going to slightly go down or it's going to stay the same. So what we're looking at these fatty streaks is a temporary, basically what we're looking at are scabs, the artery version of a scab. Okay? You get a scratch on your skin. You're going to get an inflammatory response. You're going to get cells that come in and eat up injured tissue and bacteria and whatever. And then you're going to get blood clot, and you're going to get a scab. And that scab is going to stay there until the underlying tissue has healed, and then the scab will go away. In an artery wall, you get injury, you get macrophages coming in an inflammatory response, and they eat up oxidized LDLs, and then they get under the endothelium and they form that fatty streak. And it gives time for that endothelial lining to heal. And then the fatty streak goes away. Yes? They get reabsorbed. Yeah. The body just reabsorbs the tissue. And you remember we talked about the outcomes of injury, right? And the ideal outcome is complete resolution. Okay? That's what usually happens. But what's the outcome of persistent injury? Chronic inflammation that leads to fibrosis and loss of function. Okay? So so basically, the reason why it starts at about 1 year old is because now this child is basically in the world. Okay? And every time that kid gets walked down Fort Washington Avenue on a nice sunny day and breathes in a bunch of fumes from the cars, okay, all those little chemicals are going to come in and injure the endothelial lining. Okay? And then it forms a fatty streak and it heals. Okay? You decide you want to eat an awesome banana nut muffin in the morning, ones that like size of your head. Okay, that's going to cause this spike in triglycerides in your body, which can also cause endothelial injury. Right? But that's going to heal. So injury to the endothelium can either form a fatty streak and then heal, or it can form a fatty streak, you get constant injury, and it leads to a plaque. Make sense? So a plaque is really the result of persistent injury and chronic inflammation. Okay? Why don't we let's take 10 minutes, stretch our legs.
All right, guys, let's continue. Okay. So as I mentioned, atherosclerotic plaque.
So how exactly does a plaque develop? And there's a lot of different ways to answer that question. There's still quite a lot of study going into the exact mechanism that underlies the development of a plaque. And what I mean by that is exactly what cells in the immune system are involved, what are the exact steps. But there are some sort of accepted ideas that have sort of been accepted as being clearly part of the process. So number one, that this is what underlies the pathogenesis of atherosclerosis is an inflammatory process. Okay? So what initiates this inflammatory process is some form of endothelial injury. Okay? Smoking, hypertension, diabetes, dyslipidemia, autoimmunity, infection, okay? Any number of forms of endothelial injury. Once that injury takes place, the injured endothelial cells, they release cytokines and begin to express adhesion proteins that attract monocytes and macrophages. Okay? So while, when we spoke about acute inflammatory responses, the neutrophils were our first responders, right? They migrate to the area first. When it comes to atherosclerosis, there seems to be a much bigger role for monocytes and macrophages. Okay? There's not a lot of discussion about neutrophils. So the monocytes and macrophages, they arrive or they congregate where this endothelium is injured. And the macrophages release enzymes and reactive oxygen species, as we know that they do. Now, those reactive oxygen species and enzymes actually cause further injury to the endothelium. Okay? And since they're releasing these reactive oxygen species in the blood, we know that the blood is going to have LDLs in it, right? The plasma is going to have LDLs. So the macrophages actually cause neighboring LDLs to oxidize. Okay? So not only are LDLs a factor that can initiate atherosclerosis, okay, whether they initiate it or not, they are part of the process, okay, because they're going to be oxidized when those macrophages release their reactive oxygen species. And so what we get once this process matures is what we're looking at here, which is a typical fairly mature plaque. Okay? So what does one of these typical fairly mature plaques look like? So this is the intima. Okay? We have foam cells, those LDL engorged macrophages in the core of this plaque. But as you can see, the core of this plaque is also, those fibers here are collagen fibers and a lot of dead tissue. Okay? And then covering this core is a fibrous cap. Okay? We've got a thin layer of endothelial cells on top. We have proliferation of smooth muscle cells. We have macrophages. Okay. We have collagen. And this plaque, it's not a newly formed plaque. This plaque has been around for a little while. Okay. And the older a plaque gets, the larger it gets, and the more scar tissue that it accumulates. Okay. And you can get to the point where this plaque gets so large that it starts to impinge on the blood flow to the rest of the wall of the artery. You remember we saw that artery that had blood flow, had little arterial vessels perfusing it. Okay? These plaques can get so big it can cut off blood flow to the rest of the artery wall and cause the transformation of the artery wall from muscle to scar tissue. Okay? And that's when we start to get what we call arteriosclerosis. Okay? There's atherosclerosis, which is just the presence of the plaque. Okay? And depending on how old this plaque is, we can actually reverse it. But once we start to see arteriosclerosis coming in, fibrosis of the rest of the wall of the artery, that's when we're not reversing this process. Okay? We can even start to see calcification in the artery wall. Okay? Calcification happens when cells die. You can get calcium deposits. Okay? And that's what we see over here on this is a gnarly looking piece of artery, right? When you ever hear of the term hardened arteries, this is what we're talking about, right? Arteriosclerosis. Now let's take a look at atherosclerosis developing, starting from the initial injury to the development of the plaque. So we have this nice, beautiful artery here, okay? There's no plaque, there's no issues. But we do have the presence of ongoing sources of injury, okay? We have hypertension, with smoking, elevated LDLs, okay? Inflammatory mediators. So if you have some other source of ongoing inflammation in your body, like some kind of autoimmune process, rheumatoid arthritis, or some other kind of autoimmune problem, then you will have potentially inflammatory mediators circulating, which can actually also contribute to this injury. Okay? The injury to the endothelium is then going to trigger the endothelial cells to release cytokines that trigger inflammation, right? So these macrophages migrate to the area, okay? So these macrophages have migrated to the area and they adhere to the endothelium. Now, when we studied inflammation, we studied what happens to the endothelial cells in an inflammatory response. They become more permeable, right? The pores get a little bigger, and what happens to the macrophages or the neutrophils that migrate to the area? What do when they get there? They transmigrate, right? They go through that endothelium. Now that's what's going to happen here, except this is not a capillary, so the other side of the endothelium isn't the interstitial space, right? The other side of the endothelium is the intima. So when the macrophages get there, they're doing their thing. They're releasing reactive oxygen species, they're further injuring the endothelium, and the endothelial cells become more porous, right, more permeable. Plasma gets in that intima, and LDLs come in with the plasma. And then the reactive oxygen species oxidize those LDLs. The macrophages get through that endothelium, and they start eating up those oxidized LDLs. Okay. And so if it's an acute, let me back up. If the source of the injury is acute, if it's an acute injury and an inflammatory response, and then the inflammatory response turns into a healing response, now what we have are foam cells under the endothelial lining, which is going to look like what? A fatty streak. But we don't have acute injury. We have persistent injury. Okay? So instead of turning into a healing response, we get further inflammation and further recruitment of macrophages. Right? More oxidation of LDLs. More macrophages getting into that intima. Okay? And now what we have is this intima that's getting more and more, accumulating more and more of these macrophages, right, that are engorged with cholesterol. We start to get the triggering of production of collagen and proliferation of smooth muscle cells, okay, which is sort of part of forming a scar. And then as time goes by, that you get more and more of this process. And eventually, like I mentioned, you're going to get an inner core, right, where there may be some dead necrotic tissue. You'll have lots of foam cells, collagen, smooth muscle, and a cap on your plaque. Okay. So these plaques, when they form early on, they are mostly filled with lipid. They're mostly filled with foam cells. And they just have a tiny little fibrous cap. Okay? And as they get older, as they've been around for longer, they get larger, they get more fibrous, okay? More dead tissue at the center. And if things aren't turned around, if those factors causing injury are not interrupted, it's going to lead to that hardening of the artery wall, or that arteriosclerosis. Okay. Does that make sense? So, why are atherosclerotic plaques so troublesome? Well, there's a couple reasons. Plaques are bad because they decrease the diameter of the vessel. And what goes up dramatically when we narrow the vessel diameter? Resistance to flow. Resistance to flow. When we narrow the vessel diameter, resistance to flow goes up dramatically, which reduces blood flow. Okay? So that's a problem. It can reduce blood flow. Another major problem is that endothelium is actually designed to help regulate blood flow, right? And those endothelial cells are just shattered by this process. So they can no longer really help regulate blood flow through this vessel, okay, because they are severely injured. And that becomes a real problem, especially as it relates to heart disease. That idea will come back when we talk about heart disease. Okay? So it can cause blood flow problems. So that's bad, definitely. But the most catastrophic complication of atherosclerosis is in the form of plaque rupture and occlusion of the vessel. Okay? So the most catastrophic complication of atherosclerosis occurs if you get rupture of this plaque. Okay? And what I mean by that, so we have this pretty picture. Okay? Over on the top left, we have this lovely artery with just nice, pristine walls, good blood flow. Okay. Then, we see a fatty streak, still no problem. All good. We'll heal. Oh, fatty streak is getting bigger. That's not good. We start to see the formation of a plaque. Now you notice that this early plaque, it's mostly lipid, right? It's mostly lipid. There's some sparse scar tissue on top. It's got a cap, but it's mostly lipid. Now, this plaque may rupture. And rupture is on the bottom here left. And if a plaque is going to rupture, it's going to rupture exactly where it's illustrated. It's what's called the shoulder of the plaque. So it's the point on the plaque where it starts to come off the vessel wall and you have oncoming blood flow, because that's the weakest point on that plaque. So it ruptures, and then you get this underlying collagen exposed to oncoming blood flow. That is a very good trigger to the clotting cascade. So you get a rupture. Notice that that rupture dramatically reduces blood flow. Okay? That person's going to notice this. No matter where this artery is, that person's going to notice this. Okay? If it's in the carotid artery, you're going to immediately see some kind of neurological change. Okay? If it's in a coronary artery, it's going to feel like a heart attack. Okay? That dramatic reduction in blood flow. That triggers the formation of a plaque. Now, the plaque might form and just stop at a small plaque and not occlude the vessel. Okay? And if this is in a, as I said, coronary artery, it's going to feel like a heart attack, but it's not going to be a heart attack. It's going to be classified as what we call unstable angina, okay? Which is a almost heart attack. But it can also cause a clot that continues and completely occludes the vessel. When it completely occludes the vessel, you get no blood flow to downstream tissue, and you're going to get tissue death or infarction of tissue. Okay? Infarction means tissue death. And that's really the most catastrophic complication of plaque rupture or of atherosclerosis. Okay? So if that's the most dangerous complication, then it's important to understand what increases the risk of that happening. Okay? What factors, what characteristics of a plaque increase the risk of rupture? And there's two major ones. There's what's called stress on the cap, so the stress that the cap is under. And the other major factor is the overall weakness of the plaque. Okay? So how much stress is this cap under, and how weak is this plaque? Okay? Now, stress on the cap. Notice that what caused this plaque to rupture was the stress of oncoming blood flow onto the cap. Okay? Interestingly, the stress on the cap is going to be proportional to two factors. The pressure in the vessel and the radius of the vessel. Okay? Pressure of the vessel and the radius of the vessel. Now, let's say that you have two large arteries, both under the same pressure. Okay? Plaque 1 in vessel 1 is a small plaque. Plaque 2 in vessel 2 is a large plaque. Okay? Plaque 1 in vessel 1 with it's a small plaque, and it leaves a larger radius, which allows more blood flow. Okay? That vessel, that plaque, is actually under more stress than the larger plaque that leaves a smaller radius and less blood flow that can go through. So that's the first surprising conclusion, is that smaller plaques are actually under more stress and therefore more likely to rupture than larger plaques. Yes, ma'am? Yes, that's right. That's right. It leaves more blood flow and more volume of blood, right? Generating that stress. So that's the first surprising thing, is that the smaller plaques are actually, their caps are under more stress. The second thing is the overall weakness of the plaque. Now that's related to the composition. Now, is this a plaque that's mostly lipid with just a tiny fibrous cap, right? Which is like putting a tarp over a bowl of Jell-O, right? That's a weak cap, or that's a weak plaque. Or is this a plaque that has a lot of scar tissue and less fat to it? Because that's going to be a stronger plaque. So the overall weakness is going to be about the lipid to protein ratio. Okay? And that is really going to be about the age of the plaque. Newly formed plaques are mostly lipid. Okay? Newly formed plaques are mostly lipid. And those lipids are coming from foam cells that are still releasing reactive oxygen species. Okay? So not only do you have the bowl of Jell-O covered in a tarp, right? That Jell-O is really reactive. Okay? So, and older plaques have less lipid and more scar tissue. So the second surprising conclusion is that newly formed plaques are more likely to rupture than older plaques. And if we put those two factors together, newly formed plaques tend to be small and mostly lipid. And so they tend to be the ones that are most likely to rupture, as opposed to the plaques that are larger, they've been there longer. Okay? They are less likely to rupture. One second. So let me pose a question to you. We've got two plaques. We've got a plaque that's newly formed, it's small, it's unstable, and we got this plaque that's been around forever. Okay? It's old, it's crotchy, it's mostly scar tissue. Which of those two plaques do you expect to cause symptoms? The older one. And so that means that the small plaque, newly formed, is more likely to be a silent plaque, not causing symptoms. And that happens to be the plaque that is more likely to rupture and cause the catastrophic problem. Okay? So that's often a challenging problem. Yes, Roxanne? So the problem generally when the plaque ruptures isn't stuff breaking off and traveling. The problem is generally the triggering of a blood clot at the site of rupture. And so it really just becomes what's going to cause that plaque to be more likely to rupture. Does that make sense? I saw somebody's hand up there somewhere. Yeah. So it's not so much that the contents of the plaque is going to travel. That's not what we're worried about. What we're worried about is that covering to the plaque, when it gets ruptured, it's going to trigger a clot. And that clot can either be non-occlusive, meaning it doesn't totally fill up the space of the artery, and that's better than the alternative, which is a completely occlusive clot. Okay? Yes, ma'am. So the question is are you saying like what's worse, like the small plaque that ruptures but doesn't occlude, or the bigger plaque that ruptures and does occlude? So the interesting thing is that the older plaques that are more likely to be symptomatic, right? They are less likely to rupture, and because they have been around for longer, causing downstream ischemia for longer, even if they do rupture, the tissue downstream has likely already developed what we call collateral circulation. Okay? So if you have tissue that's downstream of one of these vessels with a plaque, and you're getting oxygen deprived, those cells will actually release what we call angiogenic factors. And angiogenic factors, they act on the blood vessel to create new branches, right? So oxygen-starved tissue, if it has enough time, will stimulate the formation of new blood vessels to feed it. Okay? So even if the branch with the plaque occludes, you're less likely to get cell death because you've already formed some side roads. Yes? It doesn't take very long. It can happen in a matter of a few weeks to a few months. You see this sometimes when people start strength training and they start adding more muscle, that you also start to see more vascularity, right, to feed the muscle. So that it doesn't take a huge amount of time, but it does take longer than the time course of a small new plaque, and then it rupturing. Yeah. Okay. So that's worrisome. Your small plaques that newly forming are more likely to rupture than the older plaques that are known about, right, because they're already causing symptoms. Okay. So, related, right, we've got blood clots in circulation. So a blood clot can form when a plaque ruptures, okay? Or a blood clot can form for a variety of reasons. But blood clots are not, they're not, quote unquote, supposed to be forming in the bloodstream, okay? Clots are supposed to form when there is vascular injury or tissue injury in order to reduce blood loss. Okay? So whenever a blood clot forms in circulation, it can pose some dangerous complications. Okay? Now, when a clot forms, that clot is called a thrombus. Okay? And thrombosis is the formation of blood clots. Okay, so the clot is called a thrombus. The process is thrombosis. Now, thrombosis doesn't always fully occlude a vessel. It can form and break off and form what I mentioned earlier, which is an embolus. And what's going to happen is, what happens to blood vessels, right? As you get further down the tree, the vessels get smaller and smaller. So even if the clot that broke off was a lot smaller than the vessel where it originated, as it moves down, eventually it's going to find a vessel it's bigger than. Okay? And so you get downstream occlusion with an embolus. Now, blood clots are, we looked at what they looked like before, right? We've got the conversion of fibrinogen into fibrin that causes that network of proteins, and it suspends the blood cells and proteins and all the solid matter in the blood. And we can have blood clots forming really in almost any place within the circulatory system. We can have blood clots forming in arteries. We can see them forming in veins. They can form in heart chambers, along heart valves. Okay? They can form almost anywhere. And there are three basic conditions that increase the likelihood of thrombus formation. And we call this the Vercoe's triad, okay, these three conditions. The first is endothelial injury. The second is sluggish blood flow. And the third is, obviously, increased coagulation. Okay? And that just means increased activity of the coagulation cascade, right? The coagulation factors. So endothelial injury. Either chronic endothelial injury leading to a plaque that can rupture, or acute severe endothelial injury that causes activation of the clotting cascade because of vascular injury. Okay? So endothelial injury, either prolonged and leading to plaque, or endothelial injury that immediately exposes underlying collagen. Sluggish blood flow. Sluggish blood flow, usually blood is always moving. There's never a time where blood like pools somewhere. And if blood isn't constantly moving, then there's an opportunity for coagulation factors to accumulate and inadvertently activate. Okay? So when blood coagulation factors, clotting factors can accumulate, they can end up triggering each other and forming a blood clot. And this sluggish blood flow becomes a significant issue in the context of deep vein, the development of deep vein thrombosis. So if you're not, if you have prolonged bed rest, or you're not getting up and moving for very long, prolonged sitting, you can end up with sluggish blood flow, movement back up to the heart. You also see it in chambers of the heart when people have arrhythmias or valve malformations. Okay? If you have a valve malformation that causes turbulent blood flow and blood to sort of accumulate in pockets, it can trigger clotting. Okay? And what's the arrhythmia that is dramatically associated with clotting? AFib, atrial fibrillation. Okay? You remember when the atria contract, you get that atrial kick of blood into the ventricles? Well, if the atria, instead of contracting, they just quiver, which is what's happening in atrial fibrillation, then that time frame, you just have blood hanging out. Okay? And so with atrial fibrillation, you get these moments where the blood's not moving, and it can trigger a blood clot. Okay? AFib dramatically increases the risk of stroke. Okay? Because if a blood clot forms, okay, especially in the left atria, it's going to end up getting pumped into the aorta, and it can end up getting sent to the brain. Okay? And increased coagulation speaks for itself. You have people with either inherited or acquired hypercoagulation, right? The coagulopathies. The most common acquired coagulopathy is pregnancy. It's the most common acquired hypercoagulation state. Right? And it's true for the duration of pregnancy. It starts pretty early, and for the duration of pregnancy, it's going on. Okay. Oh, I always forget that I don't have to end at 2:50. I end at 3:50. Okay. I'm always like wrapping up as we get close to 2:50. So most common acquired hypercoagulation state is pregnancy. So what if you had a pregnant lady, little pregnant lady, big belly, and she decides to go on a 10-hour flight to I don't know where. Okay? How many of Verko's triad are you going to have going on? At least 2, right? Woman's going to be sitting in her chair for a really long time, and she's already at this hypercoagulation, in this state of hypercoagulation. Okay, so she's someone you want to drink lots of water, move around. Okay. So these blood clots can form really anywhere in circulation, but depending on where they originate, where they are, if they break off, that will lead to different problems. Okay. So if you have a clot that forms in a vessel, like in an artery, it's going, and if it doesn't embolize, it's just going to create problems immediately downstream of where it forms the clot. With embolization, the clot travels, and it's going to occlude a smaller vessel down the line. Now, most emboli are blood clots. Most of the time, an embolus is a blood clot. But really, nearly anything can be an embolus. Okay? Any substance that can travel in the bloodstream and occlude a vessel qualifies as an embolus. Okay? So that can include things like an air bubble. I lived in terrible fear as soon as I learned about this thing for the rest of my life into today, of going in for medical care and getting an air embolus, right, where somebody pushes some air into your bloodstream. So pockets of air, even amniotic fluid, it's extremely rare, but you can have a little bit of amniotic fluid get into the bloodstream and embolize. Okay? You can get fat emboli, which can, again, very rare, but it can happen especially after breaking long bones, right? So you get a broken leg, and then all of a sudden you get a fat embolus. Bacteria, clumps of cancerous tumor cells, and really any foreign substance can travel in the bloodstream and occlude a vessel. But usually it's a blood clot. Now, what complications arise from that embolus depends on where it originates. Okay, where it originates. Now, if you get an embolus that originates in the venous system, okay, and probably the most common is a deep vein thrombus, a DVT. Okay. The big worry with DVTs is that it's going to embolize. Okay. Because number one, DVTs can be huge. Those deep veins are very big, and you can get a DVT that is not only wide but also long. Okay? So if that embolizes, that deep vein thrombus embolizes, the next set of capillaries or smaller vessels it's going to encounter is going to be the lungs. Okay? Because that clot is going to go up into the heart, pass through the atria and right ventricle, and get pushed into the pulmonary artery. And it's going to stop somewhere in that pulmonary circulation. Okay? And then depending on the size of that embolus, you can either have a small area affected and just pain and difficulty breathing, or you can get a massive area affected and it can be immediately fatal. Okay? So clots that start in deep, large veins are going to result in pulmonary embolus. Okay. Now, there's one exception to that, starting in the venous system, embolizing to the heart, to the lungs. What set of veins, this is a bit of an anatomy, tricky question, what set of veins pass through a set of capillaries before getting to the vena cava? Ah, that's good. Very nice. The portal circulation, the portal vein, right? The only vein is first going through tissue before it gets to the vena cava is the portal vein. It has to go through the liver before it gets to the vena cava. And if you get a portal vein thrombus, that's not going to lead to pulmonary embolus. Okay? It will likely lead to a massive GI bleed, but it won't lead to a pulmonary embolus. Okay? So portal vein thrombus is the exception to that. And if you get thrombosis in superficial veins of the lower limbs, that just tends to lead to varicose veins, which can be very, very painful. But they don't, varicose veins don't embolize to, or superficial thrombi don't embolize to the lungs. Now, what if you get an embolus that originates in the arterial system, okay, and travels through the arterial system? The vast majority of the time, an embolus moving through the arterial system actually originates on the left side of the heart. Okay? So the vast majority of the time, an embolus that moves through the arterial system actually originated on the left side of the heart. Okay? Either because of some sort of valve abnormality or arrhythmias like AFib. Okay? So it starts on the left side of the heart and then it enters the aorta. And then what problem where it gets lodged really depends on which arterial branch off of the aorta it travels to. Okay? If it goes up the carotids, it can cause a stroke. If it goes into the renal artery, it'll cause renal infarction. It really depends on where it travels to. Okay? But most of the time, that's going to originate on the left side of the heart. Okay? So just to visualize what one of these deep vein thrombi look like, you can have a deep vein thrombus forming, and part of it doesn't even have to be all of it, but part of it can break off and embolize. Okay? And that's the real significant complication. There's an intervention in the last 10 years or so that's developed. It's if you have someone with extensive deep vein thrombi or just one really, really nasty one, to prevent pulmonary embolus, you can actually insert what's called an IVC filter or an intravena caval filter, where it's a little thing, it's interventional radiology that go through the femoral artery, and they put in the not femoral artery, they go through femoral vein, and they put in the vena cava, in the abdominal vena cava, this little filter that if you get an embolization of the thrombus, it'll get caught by the filter and it won't travel to the lungs. Okay? And then clots get dissolved after a while. It takes some time for the body to dissolve a clot, but anything that gets caught in the filter eventually will get dissolved. Okay? So there's some interesting interventions to prevent pulmonary embolus. Okay? And so with DVT, what you will notice is unilateral pain, swelling, redness, okay, in the lower limbs. And it's sometimes not easy to distinguish when someone has swelling in the lower limbs. Sometimes it's really obvious because it's pretty dramatic. But if you just looked at this person's one right leg, you might not necessarily notice that there was swelling. Okay? And so it's really important to compare the limbs to each other, right, to decide whether there actually is swelling. Okay? Because this is not an abnormally sized leg, but only compared to the unaffected leg do you notice the difference. Okay? So the signs and symptoms of a DVT is not all that dissimilar from something like infection, okay? But what you're going to see, like I said, is unilateral swelling, pain, redness, okay? And it's going to be situational, right? So you may have had someone who is on bed rest or just had surgery, right? There's something situational that's going to lead you to believe that DVT is a possibility. Okay. And when occlusions happen in the arterial tree, okay, whether it's because of an embolus or a thrombus, okay, any kind of occlusion in the arterial tree is going to cause, like I mentioned earlier, ischemia or infarction of tissue downstream from the occlusion. Okay? And so major arterial occlusion will have signs and symptoms that are related to the branch that's getting occluded. Okay? So neurological dysfunctions will come about from occlusions in the carotid artery system. Okay? Mesenteric artery, okay, so the artery that perfuses the gut. You'll have things like bowel ischemia and necrosis, right, gangrene of the bowel, and lots of GI symptoms related to that. Okay? And so it can really be devastating because you have these large arteries perfusing large downstream parts of the body. Okay, questions about that? Before I jump to aneurysms? Yes, ma'am. Collagen. Yeah. So the rupture of a plaque, that cap that covers the plaque, it has collagen inside. So when it ruptures, that's a really strong trigger for clotting. Yeah. Yes, ma'am. It's a good question. So it is a risk. It actually is a risk. When someone's getting an angioplasty or a stent or something that's compressing a clot to open up the vessel, usually it's not always done. So if you find a plaque that is if you find it without, it's not causing any problem, you just find it, right? They will decide whether or not they want to either stent it or open it up, depending on the size, depending on the location, and a couple of other factors. And oftentimes it's just the percentage of blockage that will determine, because that there is risks involved in doing that. But usually the benefits far outweigh, or the risk of not doing it, is much worse than the risk of causing that problem. Yeah. Yes, sir. So it's not going to make so plaques don't make the arteries more compliant. What plaques are going to do is reduce the elasticity of the artery, tend to make it more stiff. So, and that's especially true when you get arteriosclerosis setting in. And so, for example, what you see with, this used to be the norm, is that as people aged, and once you get into advanced age, you would very commonly see isolated systolic hypertension, right? Where the diastolic number was fine, but the systolic number was really high. And it was because plaques and hardening of arteries was just the norm, right? And so when you had the heart in systole, the artery wasn't expanding the way it should be, and so you got pressure shooting up, but only during systole. And so it's actually, if anything, it's actually reducing the compliance of the arteries rather than increasing it. Does that make sense? Okay. Okay, so another vessel abnormality that causes changes in blood flow or alterations in blood flow are aneurysms. And an aneurysm is described as an inappropriate vessel dilation. Now, we've got a variety of forms of aneurysms. If we compare it to the normal vessel, okay, you have what's called true aneurysms. And true aneurysms simply mean that there's no separation of the layers of the wall. What you have is simply an inappropriate dilation of the vessel. Okay, so true aneurysms differ depending on their shape. You can have what's called a saccular true aneurysm, okay, where only one side is dilated. And you can have what's called a fusiform aneurysm, where the vessel is dilated throughout its circumference. Okay. We also see what's called false aneurysms, and these are very dangerous. These have a high likelihood of rupture. But basically, with a false aneurysm, the reason why it's called false is because it's not a true dilation of the entire wall of the vessel. What actually happens is that it's associated with a break in the vessel wall and the formation of a hematoma between the wall of the artery and the connective tissue covering the artery. Okay. These false aneurysms are not uncommon. Okay? And usually the hematoma is capable of preventing any further bleeding or blood loss, and the wall heals. Okay? But if you look at risk factors for things like anticoagulants or fibrinolytic drugs that dissolve clots, one of the things that makes those drugs so dangerous is that if you give someone too much of a fibrinolytic drug, it's going to break down hematomas in hidden false aneurysms, and it can cause spontaneous hemorrhage because of that. Okay? And so you see things like that in the GI tract and in intracerebral vessels. Okay? So intracerebral bleeding and GI bleeding is a major concern when it comes to giving fibrinolytic drugs, okay, because it ends up dissolving these hematomas and false aneurysms. And then finally, not really an aneurysm, but is sort of grouped with aneurysms, are dissections, arterial dissections. And what happens with a dissection is the layers of the artery wall separate, and blood moves through what we call a false lumen. It actually forms a false lumen. Okay? And so you get this sort of tearing apart of the vessel wall. And what causes this to be so dangerous is that it can end up taking a significant amount of blood flow out of circulation. Okay. And probably the most dangerous form and most common form of these dissections is an aortic dissection. Okay. And if you remember the actor John Ritter from Three's Company, I grew up watching that show. My parents didn't really understand how really dirty it was, so let us watch it. But he died a few years ago from an aortic dissection. It's something that happens really fast, and it's a pretty quickly fatal problem. And aortic dissections present very similarly to myocardial infarctions, or can. Okay. And so usually when somebody presents with myocardial infarction, one of the first things they try to do is to rule out aortic dissection. Okay. So some common aneurysms that we see, abdominal aortic aneurysms is a fusiform true aneurysm that occurs in the abdominal area of the aorta. Okay? And it's most commonly associated with atherosclerosis, especially uncontrolled, significant chronic atherosclerosis. Okay? So the atherosclerosis weakens the artery wall and causes this aneurysm. Okay. So clinical features and consequences. So rupture into the peritoneal cavity or retroperitoneal tissue with massive potential fatal hemorrhage. That's really the major fear, is if this aortic aneurysm ruptures, okay? Because it's going to be really catastrophic if that happens. Okay. The aneurysm can also cause obstruction to branches that are coming off of that abdominal aorta, like the iliac, renal, mesenteric, or vertebral. Okay. And so it can cause ischemia and damage to downstream tissue. You can also get sluggish or turbulent blood flow through the aneurysm, leading to thrombus and embolism. Okay. You can have compression or impingement on adjacent structures like the vertebral column or like the ureters. And these abdominal aortic aneurysms will tend to present as palpable abdominal masses that pulsate. Okay. And it can simulate a tumor, right? Vertebral tumors can do the same. They can be palpable masses that tend to pulsate. So usually the management of these aneurysms depends on the size. So because the risk of rupture is dependent on the size of the aneurysm. Okay. So depending on the size, if an abdominal aneurysm is found, it's going to be monitored and measured frequently, and only if it gets above about 4 centimeters is there going to be surgical intervention. Thoracic aortic aneurysms. This is where you see either a fusiform or a saccular aneurysm in the aorta, right, located in the thoracic cavity. And it's most commonly associated with hypertension, uncontrolled significant hypertension. Okay. So with a thoracic aneurysm, some of the problems that can arise is encroachment on other structures in that mediastinal area, which means that middle area of the thoracic cavity. You can have respiratory difficulties because of encroachment on parts of the lungs or the airway, difficulty swallowing because of compression of the esophagus, persistent cough because of irritation or pressure on the laryngeal nerves, pain caused by erosion of bone, either vertebral or the ribs. That compression of the bone can cause erosion. You can have cardiac diseases because of the pressure changes within aortic aneurysm. It can cause aortic valve dilation, AV valve insufficiencies, narrowing of parts of the opening to the coronary arteries, which can cause ischemia to the heart. And, of course, the major concern is rupture. Okay. And again, intervention is going to be dependent on the size of the aneurysm, and it's going to be closely watched. Now, aortic dissection, as I mentioned, is when you get rupture of the inner lining of the artery wall, and then blood pushes its way through the layers, forming a false lumen. And the severity of an aortic dissection really depends on how much blood dissects and where the dissection is. And so several types of dissections are classified based on the location of the dissection and how much blood pushes its way through the wall. Okay. Generally, we see aortic dissections in men between the ages of 40 and 60, okay, who have long-standing hypertension. Okay. So more than 90% of dissection cases fall under this category. So men in basically middle to advanced age with long-standing hypertension. And then another smaller proportion of patients are patients with essentially connective tissue abnormalities. So syndromes like Marfan's that causes connective tissue abnormalities can cause patients to develop dissections at really any age, including very young ages. Dissections can also be iatrogenic, meaning caused by medical care, and it can be a complication of arterial cannulations during diagnostic catheterization. When you're getting radiologic imaging, right, of the arteries, you can actually cause a dissection, or cardiopulmonary bypass, right? So someone who's getting thoracic surgery or heart surgery and is dependent on cardiopulmonary bypass, that can also cause dissection. Classic clinical symptoms of aortic dissection: sudden onset of excruciating pain, usually beginning in the anterior chest and radiating to the back, scapula, right, the shoulders, and downward as the dissection progresses. Okay. The pain can be confused with myocardial infarction. So they present very similarly. Okay. Most common cause of death is rupture of the dissection outward into the pericardium, pleural or peritoneal cavities, so hemorrhage, basically. Okay. All right. Questions? Okay. Well, I'm going to let you out early on this lovely Tuesday. And for those of you that requested to view your exam, we'll just do it a little bit earlier, okay? So enjoy the rest of your day, and I am just going to set things up, so give me like 10 minutes before we view tests.
So what's left is regulation of blood pressure, and I'm just going to combine it with hypertension.
Okay.
Yeah.
Thank you.
You're welcome.
Hi, everybody. So, couple of things. If you responded to the Friday solicitation that went out for the Friday session, we haven't printed those off yet, so I don't actually have your exam if you responded to for the Friday session. But if you responded for today's session, I have it. Okay. What I also realized was we can't like do an actual, I can let you guys look at them, but I can't do the review until 3:50 or else Echo is going to capture it. So so it'll take us some time to hand it out. So what I'll do is if you guys can just come as close to the front as you can, I'm happy to let you look at it. So one thing is that you just have to hand it back to me, like don't take pictures of it or crazy things like that, okay?